Good evening. Welcome to this subject seminar on gastroesophageal reflux disease and Barrett's esophagus. After the last class of anatomy and physiology of esophagus, we are moving to the most important benign conditions afflicting the esophagus. So, Likith, over to you.
Yes, sir. Good evening, all. Today we'll be discussing about two topics. First is GRD and next Barrett's esophagus. Uh, Starting with GRD, it is a condition in which there is retrograde flow of stomach contents into esophagus or beyond into the regions like oral cavity, larynx, and the lungs, and resulting in inflammation of the esophageal mucosa. In Western countries, the prevalence of this disease is approximately 10 to 20%, and the severe disease is observed in 6% of population. In Asian countries, the prevalence is approximately 5%, and during pregnancy, approximately half of women experience a reflux. The prevalence increases throughout the pregnancy, affecting 20 to 30% of women in the first trimester, and 40 to 45% in second trimester, and 60% in third trimester. Next, coming to the gastroesophageal junction anatomy, it is a complex valvular mechanism at the gastroesophageal junction, which antagonizes the positive abdominal pressure and negative thoracic pressure. This anatomical structures compromises following, like lower esophageal sphincter. This
Not
is
com-
the
Not compromises, comprises.
com this comprise yes this
Okay.
comprises the following structures, like lower esophageal sphincter. This physiological sphincter measures 3 to 5 centimeter long, and the high resting tone of the smooth muscle in the lower esophageal sphincter prevents the regurgitation of gastric contents into the esophagus. And next is diaphragm. This is the esophagus enters the abdominal cavity through diaphragmatic hernia hiatus, and the diaphragm provides extrinsic reinforcement to the lower esophageal sphincter. And abdominal portion of the esophagus, this esophageal segment is exposed to the positive intra-abdominal pressure and collapses without a bolus. And this collapse provides further support to the lower esophageal sphincter. And coming to the angle of His, it is acute angle between the esophagus and the gastric fundus, which enhances the function of lower esophageal sphincter. And the phenoesophageal membrane, this is a fibroelastic ligament that continues the transversalis fascia, which leaves the diaphragm and surrounds the esophagus. And next, physiological mechanisms also protect against the gastroesophageal reflux include esophageal motility, like peristalsis promotes the return of regurgitated acid into the stomach, and saliva production. This saliva consists of bicarbonates and it is slightly alkaline. And esophageal epithelial protection, with esophageal submucosal glands also secretes mucin and bicarbonate, which protect the distal segment of esophagus and from acidic contents from the stomach.
So
And
what is esophageal clearing acid clearing mechanism? Likith.
that is,
Esophageal acid clearing mechanism. Acid clearance it is called.
yes,
What is it?
sorry, due to peristalsis and this submucosal glands this mucosal gland secretes bicarbonates and mucin, which
It is constantly, as you said, the peristalsis with the aid of the saliva and the bicarbonate in the saliva and the mucus, it constantly washes the acid that has reflux
yes,
into the
stomach,
esophagus.
esophagus.
So once the uh, reflux, see normally there is reflux of about what is the percentage? Anybody can answer this question. What is the percentage of reflux that happens in a normal individual? Anybody? in a given day, 24 hours, what percentage of the day there is a reflux going on?
Sir, usually it can occur up to like 40 to 50 times per day, sir.
No,
Amount might be equal to like 50 ml each time, sir, probably.
so what percentage of the day you will is when you will have reflux happening? Let us say 24 hours. You are right.
10%, sir.
10 to 15%, sir.
I think that is a guesswork. So
Yes.
I will not give you the answer. You need to find out and put it up in the group. But what is
Yes.
important is the reflux happens in a low altitude reflux and significant reflux. If you look at the esophageal manometry and this one pH monitoring, 24-hour pH monitoring, you will see there are times when the reflux goes on at a very low level, and then there are significant spikes of this. So when people who have this gastroesophageal reflux disease, that percentage goes up, and the ability of the esophagus, the acid clearing mechanism is overwhelmed. So when that happens, you start getting gastroesophageal reflux disease, which can be initially asymptomatic, later can become symptomatic. Okay, carry on.
Yes. Yes. Next, some of the underlying etiologies of GERD include transient relaxation of lower esophageal sphincter or lower esophageal sphincter pressure, and hiatus hernia, and increased intra-abdominal pressure extrinsically as in obesity and intrinsically observed in during pregnancy or in patients with high volume ascites, and impaired esophageal motility, saliva production, and esophageal mucosal defense mechanisms. And certain individuals are at increased risk of developing GERD. And these risk factors include male sex, white ethnicity, and age 50 or older, tobacco use, alcohol consumption, and delayed gastric emptying, chronically decreased thoracic pressure, and use of aspirin and other non-steroidal anti-inflammatory drugs, and use of drugs that reduce lower esophageal sphincter pressure includes nitrates, calcium channel blockers, anticholinergics, alpha-adrenergic agonists, and theophylline and morphine. And lastly, anxiety and depression. Pathophysiological mechanisms underlying GERD are related to etiological causes, that is transient lower esophageal sphincter relaxation. This change result in regurgitation of gastric acid, enzymes, and bile acids into the esophagus. The effect is enhanced in patients with increased intra-abdominal pressure, such as patients with ascites and pregnant women. And hiatus hernia. In this hiatus hernia disturbs the anatomical relationship between the diaphragm and the lower esophageal sphincter function, and also hernias can act as reservoir for gastric contents, which can reflex into the esophagus when lower esophageal sphincter relaxes during swallowing. And increased intra-abdominal fat, this change increases the gastroesophageal pressure gradient and the frequency of transient transient relaxation of lower esophageal sphincter phase, and leading to the reflux of gastric contents into the esophagus. An impaired physiological defense mechanism, this is dysregulation of esophageal peristalsis, could lead to ineffective clearance of acids from the lower esophagus. And impaired saliva production, the process of neutralizing the acids refluxed into the esophagus decreases. And impaired epithelial defense mechanism typically include the defect in tight intracellular junctions and cellular and intercellular buffers and cell membrane transport proteins. Most common symptoms of GERD are heartburn, regurgitation, and chest pain. Heartburn is primarily felt behind the sternum within 60 minutes of eating, like typically precipitated by exercising or lying in a recumbent position. And dysphagia is reported in 30% of patients with reflux esophagitis associated with peptic strictures and weak peristalsis or mucosal inflammation. And patients may also present with atypical symptoms like where chronic cough. The underlying pathogenesis of cough in reflux esophagitis can be explained by stimulation of esophageal bronchial reflux. And alternatively, chronic cough may be due to pharynx or larynx irritation by acids. And in patients with asthma, autonomic dysregulation occurs, resulting in increased vagal tone, and this change together with increased negative intrathoracic pressure during asthma could enhance the tendency of reflux. And extraesophageal symptoms, this is due to pathological symptoms changes secondary to GERD include dysphonia like hoarseness, vocal hoarseness, and sore throat and laryngospasm. Diagnosis of GERD is based on clinical features, and the patient responds to a PPI proton pump inhibitor trial regimen and diagnostic studies. And when the patient presenting symptom is chest pain, cardiac disease must be excluded before performing gastrointestinal evaluation. And unless alarm symptoms are present, patients should be initiated on empiric therapy with proton pump inhibitors. And patients presenting with typical GERD symptoms associated with any of the alarm symptoms or atypical symptoms should be examined with esophagogastroduodenoscopy. And performing endoscopy may be indicated in high-risk group, particularly who are overweight and age greater than 50 or older, or patients who had chronic esophageal reflux. And the Los Angeles classification includes the following grades of reflux esophagitis, and grade A is greater than or equal to 1 esophageal mucosal breaks, which is less than 5 mm long, and grade B includes greater than or equal to 1 mucosal breaks, which is greater than 5 mm long, but continuity across mucosal folds. And grade C, there are continuous mucosal breaks between the tops of greater than or equal to 2 mucosal folds involving less than 75% of the esophageal circumference. And grade D, mucosal breaks involving like greater than 75% of the esophageal sphincter. And esophageal manometry is of limited role in the primary diagnosis of GERD. However, manometry is recommended before anti-reflux surgeries to rule out like achalasia or severe dysmotility disorders, or as in like scleroderma like esophagus. And next is ambulatory esophageal pH monitoring. It is the only test that determines the abnormal acid reflux and frequency. This test is indicated in cases of medically refracted GERD and patients with extraesophageal symptoms suggestive of GERD. Ambulatory reflux pH with or without impedance monitoring can be done in 3 following ways, like 24-hour transnasal catheter measuring distal esophageal pH, and next is a 48-hour or up to 96-hour wireless pH monitoring utilizing a small capsule endoscopically pinned to the distal esophageal mucosa. And the patient is given a handheld recording device with which symptoms can be documented and timed. And if the esophageal pH is lower at the time of one or more of these symptoms, this would indicate that the symptoms are due to acid reflux. And next is combined multi-channel intrahumeral impedance and pH testing. It utilizes a 24-hour transnasal catheter In impedance testing, it identifies mild acid reflux that pH monitoring may not diagnose when used alone. And ambulatory esophageal reflux monitoring is the only available test that detects pathological acid exposure, like frequency of reflux episodes and correlation of symptoms with reflux episodes. And coming to management in patients with
just
a
a minute,
minimal. Yes.
just a minute, stop.
Yes.
So, any questions so far? Go back to the
Sir,
endoscopy picture.
I just wanted.
Just a minute, go back to the endoscopy. Nikita, comment about the first picture. What is it?
The picture depicts the endoscopic view of the esophagus, sir, with mild ulcerations.
Okay. What else is there?
There is a hiatus hernia. It looks like there
Correct.
is some higher component
There
of
is
hiatus hernia, sir.
there is a 3 to 5 centimeter hiatus hernia, and then you can see the
Yes.
ulceration. It's small ulcers. So, but gastroenterologists frequently point this out. I don't know whether you can see. I know, I think it's difficult. Likith, or
Yes.
just point this first one, the ring on your.
This
Aroma.
Use
this
the
one, sir.
arrow. Use the arrow. Point the ring.
Arrow is visible, sir.
It's no, it's not depicted.
Now go to the thing and take the arrow and show the ring. Can
No, sir,
you?
it is not.
Wait, this is it's coming now.
No, we can't see.
Sanya, can you do
This
that on?
Now
Correct. Yeah.
yes.
So go around that. Go around that. Yeah. So what the gastroenterologist, I have seen at least 3 consultant gastroenterologists record this as Schatzki's ring. This is not Schatzki's ring.
Oh,
Schatzki's ring is a vascular ring. So this is, as you said, it is a hiatus hernia, maybe 3 to 5 centimeters with the, show the mucosal break there. Show the mucosal break. There. Yeah. So that is a mucosal break. So that is level A, Los Angeles classification grade A. Show the grade B and grade C and all that.
yes, sir. This is the mucosal break, sir.
See, there is
This
multiple ones here.
multiple.
Virtually the entire circumference is involved.
Yes.
Grade 4, virtually the entire circumference is involved. Okay. Okay. You were saying, Nikita, question?
sir, he told empiric therapy, but is he going to talk about empiric therapy also, sir? Or
No. Empiric
Likith,
therapy will
what is
be.
empiric therapy?
Empiric therapy will be
No, sir, I just
start.
wanted to know.
Likith, what is empiric therapy?
Sir, initially like 8 to for 1 to 1.5 month will start on patient on this proton pump inhibitors.
No. I think why that's not that long. See, what is the indication for doing endoscopy?
Like
Anybody can answer that question.
So not settling with empiric therapy, sir, and severe symptoms.
symptom.
No, but severe symptoms, yes, but duration is very important. What does the British Society of Gastroenterology and American Society of Gastroenterology recommend?
More than a month, sir?
No,
8 to 6 weeks.
no.
6 to
Anybody?
Sir, for first 2 weeks, if the symptoms are not settling with empirical therapy, then we have to think for endoscopy.
No. So basically, let us say somebody had an upper respiratory infection or some headache, and they took antibiotics and NSAIDs, and then they develop severe gastroesophageal reflux. So you don't recommend endoscopy for them because you can see that there is a triggering factor, there is a etiologic factor for their GERD or acidity like symptoms. So just you can empirically treat it for a week or so and then stop it. Once the offending agent is stopped, the symptoms will come down. So generally, whenever there is some trigger for their symptoms, then you can give them empiric therapy for a short period, which should not last more than a week, and then re-evaluate the patient. But the definitive indication for endoscopy would be intermittent symptoms lasting anywhere up to for 6 months, intermittent symptoms. So 6 months, then you definitely recommend endoscopy, or continuous symptoms for a period of 3 months. As you said, even with the um, empirical therapy, there is no the moment they stop it, they get the symptoms again. So anybody whose symptoms are lasting for 3 months, you have to recommend endoscopy. If they have intermittent symptoms over a period of 6 months, then also they recommend endoscopy. And the other thing is, many of them will have silent gastroesophageal reflux, which they would have ignored, and they would usually call it as gastric symptoms and just ignore it. Such patients, and especially patients who have high risk, like patients who are consume significant amount of alcohol, or patients who smoke a lot, or patients who are on certain medications which causes reduced lower esophageal sphincter, and such people, and patients who are obese, what you do is you have to at least have a baseline endoscopy to see what you are seeing. So when you see that, you will know whether there is Barrett's, whether there is hiatus hernia, and then there are other, sometimes they can, because even achalasia cardia will also present like with upper GI symptoms, the reflux symptoms similarly initially, only later it becomes different, but initially it will be the same. So you will be able to diagnose any of these conditions. So you have a baseline endoscopy, and then you can treat these patients. Sometimes you may even pick up malignancy also, especially people in the age of 650, 60, who are chronic smokers and things like that. The first thing you do when you endoscope them, you may pick up an esophageal malignancy, because the incidence of lower esophageal, the junction tumors, what we call as gastroesophageal junction tumors, are increasing, and many of them are now no longer squamous cell carcinomas, but they are adenocarcinomas. So, and their prognosis is much worse compared to squamous cell carcinomas of the lower third or middle third. So, for all these reasons, you have to endoscope them, at least have a baseline endoscopy, and more so in patients, as I suggested, patients who have continuous symptoms for a period of 3 months, or intermittent symptoms lasting up to 6 months or beyond, and patients who have high risk and maybe family history of esophageal cancer and things like that, you should have and family history of gastric cancers, you should have an upper GI endoscopy as a baseline. Okay, right. Any questions? Doubts? Okay, carry on, Likith.
Yes.
So are you talking about the D-Mister score or not?
D-Mister score? No, sir, it is. In last class, I have explained. Huh. Today, no, sir.
No, but D-Mister score is one of the definitive thing for surgical management, right?
Sir, it is great if it is greater than 13.
So that is what you see. It would have been better if you had put it up so that it would be a refreshment. This one reinforcement of what D-Mister score is. Okay, carry on.
Yes, yes, sir.
Who did the last class? Samir.
Yes, sir.
Samir, educate us about D-Mister score. What is the significance? Just let us have a recap.
Sir, manometry was still like pending, sir, from the year.
So you have not spoken about D-Mister score.
No, sir. I was just starting manometry,
Huh.
and until that, actually, time was up, sir.
So all of you, homework, who is Tom Demister and what did he do? What is his contribution? He's not only just Demister score, I think he's one of the most famous esophageal surgeons. So let us know about what is Demister score and what is the score beyond which surgical treatment is indicated. Homework, okay?
Yes.
Okay,
Yes, sir.
right. Carry on.
Yes. And in patients with minimal to moderate symptoms of GERD, management typically involves implementing lifestyle modifications and PPI therapy with additional pharmacological treatment. And these lifestyle modifications are considered the cornerstone of any therapy for patients with GERD. And counseling should be provided about the importance of weight loss, given that the underlying obesity is significant risk factor for development of GERD. And patients should also be counseled to avoid meals at least 3 hours before bedtime and to maintain good sleep hygiene, and as well as minimal sleep disturbances are associated with decreased reflux episodes. And studies also shown improvements in symptoms of GERD and pH monitoring studies with elevating the head of the bed. And avoid trigger foods and beverages, example chocolate, caffeine, alcohol, and spicy foods, as well as avoid tobacco products and smoking.
So what does smoking do? Ainas, you are very quiet. What does smoking do? Ainas, is
So
she there or not?
she went to attend a call, sir.
Sir, there,
Yeah.
sir.
Yeah, Ainas, tell me.
Sir, it it is this lower esophageal, like the sphincter relaxation, sir.
Correct?
So because of that, acid reflux will increase, sir.
Correct?
And sir, in general, it stimulates more gastric acid secretion, and
How?
it
How?
sir, like nicotine is stimulating the production, sir, and it
Nicotinic receptors.
yes, sir.
So it increases acid production, lowers the lower esophageal sphincter pressure. Yes, then what else?
And so this like the gastric emptying is delayed, sir.
No, gastric
Well,
emptying is not delayed. Esophageal acid clear mechanisms are interfered with. So
yes.
the esophageal acid clearing ability capacity is reduced, and also it causes localized ischemia, and hence the ulcer healing process is because of the vasoconstriction, the ulcer healing. See, everybody, whenever there is reflux, they can have erosions, they can have small ulcers, and these ulcers usually heal. But with the continued smoking, the healing process is either is definitely delayed, and sometimes it can be prevented also. So, because of all these things, smoking is a bad thing to have in conjunction with GERD. So, you have to ask the patients to stop smoking. Okay, carry on.
Yes, sir. Coming to the pharmacological therapy, medications used to treat GERD include several classes of drugs that reduce gastric acid production, as well as antacids that neutralize gastric acid. Coming to proton pump inhibitors, omeprazole was the first PPI to be approved, and also others include lansoprazole, pantoprazole, rabeprazole, esomeprazole, and omeprazole, sodium bicarbonate, and dexlansoprazole. And PPIs irreversibly block the exchange of protons and potassium cations on proton pumps in parietal cells of the stomach. And patients with suspected GERD or documented like Los Angeles classification grade A or B reflux esophagitis should be first treated with a daily PPI dose for 8 to 12 weeks, that is which is taken 30 to 30 minutes to 1 hour before food. And chronic use of PPIs drugs has been associated with intestinal infections include Clostridium difficile and norovirus, other viral causes of GE, gastroenteritis, and some multi-drug resistant bacteria. This risk is increased due to the acid suppression effect on the microbiome. And disease deficiencies of vitamin B and vitamin D and B12 and calcium, magnesium are also associated with the associated with deficiencies of vitamin D and B12 occur. This may be theoretically associated with need of gastric acid to be present for proper absorption. And histamine type 2 receptor antagonists currently available include famotidine, cimetidine. The other drugs used are ranitidine, nizatidine. These were withdrawn from the market due to the compound like NDMA. It is N-nitrosodimethylamine. It is a probable carcinogen being found in some samples of these drugs. And the newest class of medications for GERD is potassium competitive acid blockers, which may provide a more potent means of suppressing gastric acid production. And these PCABs are acid stable and have much longer half-life than PPIs, so they can be taken at any time during the day, regardless of meal times. And moreover, 7 medications of this type has been developed. In that, vonoprazan was the first approved by US FDA in late 2023, and vonoprazan is currently recommended as second-line treatment for the patients with documented acid-related reflux who had failed to respond high-dose PPI therapy. And rivaroxaban has been approved for clinical use in South Korea, and tegoprazan is marketed in like South Korea, China, and other parts of Asia, as well as in Central America and Africa. And other medications like baclofen and sucralfate are used, and baclofen has been found to decrease the number of postprandial acid reflux episodes by reducing transient lower esophageal sphincter relaxations. And patients who have medically refractory GERD and non-compliance or adverse effects with medical therapy or a large hiatus hernia or who do not to discontinue the long-term medical therapy should be considered for endoscopic or surgical management. The available surgical options for
Just a minute.
Yes.
Ainas, did he mention all the indications for surgery?
So she is in emergency, sir, right now.
Okay, right. Okay, Nikita, you answer, or Samir afterwards.
He mentioned almost all of them, sir.
No,
Refractory,
Samir, Karthik,
Think he mentioned everything, sir.
Sania.
Same, sir. I think you mentioned.
No, he did mention a lot of things. One is he said refractory to medical treatment. Then people who do not want to continue long duration of medical treatment. Then he mentioned
Hiatus.
then he mentioned hiatus hernia. Okay, but he did not
and
mention
adverse. Yes.
complications relating to reflux like is severe grade 3 grade 4 LA reflux esophagitis with severe ulceration. Then he did not mention about esophageal strictures secondary to reflux esophagitis, then those which need regular dilatation. Then he did not mention the presence of Barrett's esophagus, which if the Barrett's esophagus does not respond to the usual that is the Helicobacter pylori eradication and regular PPIs, if there is no regression of the Barrett's, then you consider doing, he's going to talk about Barrett's anyway, but Barrett's esophagus is also one of the indications for this one, for surgical management of gastroesophageal reflux disease. Okay, carry on.
Yes. And the available surgical options are
And and the last one is the Demister score. So patients with the high Demister score, after you do the esophageal pH monitoring and 24-hour pH monitoring and esophageal manometry, a certain Demister score will almost force you to offer surgical management. Okay, right.
yes. Patient the available surgical yes.
Carry
Yes.
on.
The available surgical options for GRD are like fundoplication methods and bariatric surgeries for these obese patients. This laparoscopic Nissen fundoplication is the gold standard method surgical treatment for the managing GRD. The Nissen fundoplication involves a 360-degree wrap completely wraps the gastroesophageal junction using the stomach fundus, and the there are other two most common partial fundoplications are DAR and toupee procedures. This DAR procedure is performed by folding the fundus over the anterior aspect of the esophagus and then anchoring it to the hiatus and esophagus. And toupee procedure creates a wrap around the posterior aspect of the esophagus.
Where is DOR used, Nikita?
Sir, in an already performed bariatric patient, so like already operated bariatric patient where fundus is very limited, sir.
No. DOR is generally not preferred compared to Nissen and toupee. So where is DOR usually used? I think we have already mentioned it many times. Karthik?
Sir, in the achalasia cardia post Heller's myotomy.
Correct. So post achalasia cardia surgery, Heller's myotomy, you usually, because they almost definitely, if they don't already have it, they will have significant reflux post fundoplication. Post this one, Heller's myotomy, and in such patients you do an anterior wrap. It not only serves the purpose of the prevention of acid reflux, it also will act as a buttress for the myotomy that you have done. Even if there is any small mucosal breach, the anterior wrap will prevent the leak and things like that. So it is actually a good thing to do a wrap. So that is where the definitive indication for DORS anterior wrap is. The other two are generally used for gastroesophageal reflux disease. Okay, carry on.
Yes. This bariatric surgeries has demonstrated a significantly and durable weight loss, and it has significantly evolved over the last decade. And this current bariatric surgery procedures offered include restrictive procedures such as laparoscopic vertical sleeve gastrectomy and adjustable gastric bandings, and
No.
malabsorptive procedures such as
Gastric banding is mentioned to be condemned. Nobody uses gastric banding anymore. Okay, so don't mention it.
Likith, even sleeve gastrectomy is not a procedure to be advocated for GERD patient. Sleeve is a contraindication for GERD patient, which is the only bariatric surgery which is advocated.
yes. Okay.
In fact, the sleeve will worsen GERD. Why?
It will take away the angle of his. No, that angulation is lost.
It's a high pressure system, so there will be a reflux, and it will take away the angle of his.
Oh.
So what is the recommendation? So patient is obese, morbidly obese, but patient has hiatus hernia or GERD. So what is the surgery which you will propose, which will take care of both?
Like Row-en-Y gastric bypass.
Yeah, Roux-en-Y gastric bypass is the treatment of choice.
Yes.
Sleeve is contraindicated, at least a relative contraindication. There are
Yes.
experiments which they do by doing a crural repair and doing a sleeve, but ideal procedure which has to be recommended for a patient with GERD or hiatus hernia with the bariatric surgery is Roux-en-Y gastric bypass.
Yes.
Nikita. Nikita,
Yes,
can
sir.
you tell us the what shall we say, the main steps of fund application? Where do you start? What do you do? And then, so 4 or 5 steps.
Sir, we have to initially mobilize the stomach, sir. Like gastroesophageal junction. There are few ligaments attached to the diaphragm.
Hmm.
Uh,
Where do you start? What is that point called?
point.
Karthik.
Uh, at the right crux of the diaphragm, sir, we have to release the esophagus.
No, how can you demonstrate the right crux of the diaphragm before you do something? What is that point called? Has Aina's come back? No? Samir, do you know? Tanya?
So are you asking about the gastrohepatic ligament that we are going to dissect?
Yeah, gastrohepatic ligament, but before that point is called what? Pars flaccida.
Okay.
So you have to open the this one, the along this lesser curve. You have to open this one. What shall we say? The lesser omentum, and then you enter into that space, and as you said, the gastrohepatic ligament, the phreno, this one, what ligaments are, they're all separated, and then generally you create the space posterior to the esophagus, taking care not to injure the vagus.
Vagus.
So where do you see the left vagus and the right vagus?
So left vagus is anterior to the esophagus, whereas right is little posterior lateral, sir.
Posterior lateral. Okay, LARP. Okay, so you have to create the space behind the esophagus, and then after you have done that, you will expose the right and the left crux of the diaphragm. So you have to separate nicely separate the esophagus from the two crura. Most of the time there will be a small component of hiatus hernia if it is not there, but still, most of the time there will be. And then you have to strengthen the crura by suturing that, and you can take a small bite of the esophagus while you are doing it without taking a very deep bite. And you also have to short gastric vessels of the fundus. You have to ligate them, usually using a harmonic scalpel or vessel sealer, the bipolar vessel sealer, and then you do the shoe shine maneuver using the fundus to come behind the esophagus, and it should move easily as if you would shine the shoe. And then nowadays I think it is definitely recommended to do a two-pay modification of the Nissan fund application. So you do a 2/3 wrap rather than the entire one. People used to use bougie 52 French, 50 French or 52 French bougie, or you can even use an endoscope to ensure that the lumen is adequate. So 2/3 will be sufficient. 2/3 of the wrap will be sufficient. After you have done the wrap, you can do an endoscope and confirm that your wrap is okay and the scope comes through easily. So that is these are the steps of this one fundoplication. Niranjan, anything to add?
Nothing, sir. Almost covered everything.
Okay. So you understood now what Niranjan said. If you're combining GERD with the obesity, don't do just a sleeve gastrectomy. It is actually going to be making the patient worse. You have to do an Roux-en-Y gastrojejunostomy, the RYGB, gastric bypass. Okay, carry on.
Yes. Yes. Several types of minimally invasive endoscopic techniques have been developed for managing GERD. This include the Stetta endoscopic procedure. In this, a catheter with 4 needles is endoscopically placed at the level of lower esophageal sphincter, and a balloon is inflated within the catheter, allowing the needles to break through the mucosal barrier. Then radio frequency is applied through the needles, and this results in the increase in LES, lower esophageal sphincter pressure, and the reduction in transient lower esophageal sphincter relaxations, and which improve the symptoms of GERD. This strata is used for patients who have Los Angeles classification grade A and grade B, and normal esophageal peristalsis and LES relaxation, and as determined by manometric evaluation. So they should not have a hiatus hernia larger than 2 centimeter or long segment Barrett esophagus. Next is magnetic sphincter augmentation. It is a laparoscopic operation in which approximately 2.5 centimeter a titanium ring is of metallic beads is permanently placed around the LES, and during this peristaltic movement, the bolus of liquid or food separates the beads, opening the gastroesophageal junction and allowing the bolus to pass into the stomach. And after that, the beads return to their original position to augment the LES resting pressure and significantly reduces the gastroesophageal reflux. Next is transoral incisionless fundoplication. It is performed with flexible and multi-channel endoluminal device that uses fasteners to construct a full thickness gastric plication and to create anti-reflux valve at gastroesophageal junction. This is performed under general anesthesia, and it is in this procedure a specialized device called Esofix is used and passed over the standard gastroscope and delivered transorally into the esophagus and stomach. With the endoscope in retroflexed position, the polypropylene fasteners were delivered serially as the device is rotated around its axis to create a gastroesophageal plication over a circumference of like 200 to 300 degrees. Next, complications associated with GERD include esophagitis. Patients with grade C and grade D esophagitis are characterized as having severe reflux. These patients have the lowest healing rate with PPIs and lifestyle modification. And patients with severe reflux esophagitis are more likely to relapse after treatment and have greater risk of developing Barrett esophagus. And these patients should undergo endoscopy 8 to 10 weeks after PPI. And esophageal stricture development. This dilatation is the mainstay of management. If the stricture persists despite improvement or reflux or resolution of esophagitis. In Barrett's esophagus, Barrett esophagus, this occurs in 5 to 15% of patients with reflux esophagitis. Next is esophageal adenocarcinoma. This occurs in approx 5% of patients with Barrett esophagus, especially when it involves a long segment of the esophagus. And it is approximately 8 times more common in men than women. And other complications include peptic ulcerations, upper GI bleed, and upper GI bleed, laryngitis, cough, sinusitis, bronchial asthma, and idiopathic pulmonary fibrosis and dental erosions. Next.
Okay. Yeah.
Yes, sir. Continue, sir.
Yeah, continue.
Yes. Next.
Any doubts about complications? Okay, carry on.
No, sir.
He's going to elaborate on Barrett's esophagus now. Okay.
Yes. Barrett esophagus is a premalignant condition characterized by salmon-colored mucosa extending at least 1 centimeter proximal to the GE junction and with biopsies showing columnar epithelium and goblet cells, which is indicative of intestinal metaplasia. And this columnar epithelium in the affected portion of the esophagus may become dysplastic and subsequently progresses to esophageal adenocarcinoma or adenocarcinoma of G junction. And most cases are acquired with the precipitant usually being long-standing gastroesophageal reflux. And Barrett esophagus can be found in like 5 to 12% of patients with chronic symptoms of GERD. Next, most patients with Barrett esophagus have known history of chronic GERD. The reflux of gastric acid and bile through the lower esophageal sphincter into the distal esophagus, and the stomach lining is a mucinous columnar epithelium that can withstand acid environment, which is required for digestion. And the esophagus is lined by squamous epithelium, and as a response to the acid irritant, the squamous epithelium of esophagus become inflamed, and the continuous exposure to acids lead to persistent inflammation and a columnar metaplastic reaction with the eventual development of intestinal type, which characterized by goblet cells. Coming to epidemiology, Barrett esophagus is more common in men than in women by a ratio of 2:1, and the prevalence is like 0.8% in general population and 3% in patients with GERD and 12.2% with GERD plus any other risk factor. And study results indicate the absolute annual risk of adenocarcinoma in a non-dysplastic Barrett esophagus is like 0.1 to 0.5% per year and 1 to 43% per year for low-grade dysplasia and 23 to 60% per year for high-grade dysplasia. The American College of Gastroenterology now recommends screening for Barrett esophagus in people with chronic symptoms of GERD who has at least 3 additional risk factors include like male genotype and age older than 50 years and central obesity, past or present smoking history, and family history of either Barrett esophagus or esophageal adenocarcinoma in first degree relative. And patients with chronic reflux, at least 3 risk factors considered to be high risk and should undergo screening endoscopy. Yes, gastroduodenoscopy with the forceps biopsies is the gold standard of diagnostic test. And to maximize the possibility of Barrett esophagus, the ACG recommends a minimum of like 8 biopsies, 2 from each quadrant at 2 centimeter interval for short segments of Barrett mucosa. And the Seattle biopsy protocols includes the segments greater than 4 centimeter long, which involves biopsies taken from visible lesions and followed by 4 quadrant biopsy every 2 centimeter and every 1 centimeter. And if dysplasia is suspected or known to be present. In high definition white light endoscopy and chroma endoscopy, like using topical acetic acid, methylene blue, and indigo carbine, and this increases sensitivity and specificity for identifying dysplasia and adenocarcinoma. And it is recommended that both white light and chromoendoscopy be used during endoscopy when biopsies are to be taken for suspected or previously diagnosed intestinal metaplasia. The extent of Barrett esophagus is graded by the Prague criteria, specifying the circumferential length of Barrett epithelium at and above the top of gastric folds, it is C, and the maximum extent of Barrett mucosa, which is M. Here in this picture, we can see like circumferential, it is extending from 33 to 36 centimeters, which is like 3 centimeters. C is equal to 3, and for M, it extending from 29 to 36, 38 centimeters, which is 36 centimeters, which is like 7 centimeters, that is maximum extent. And there's other procedures like wide area transepithelial sampling with computer assisted 3D three-dimensional analysis. It is an adjuvant for that may be more sensitive in identifying dysplasia. This technique involves assessing the tissue with an abrasive brush to sample the deeper mucosal tissue where dysplasia is more likely to be found. And use of this VAT 3D procedure increased the detection of Barrett mucosa by 20% and double the identification of dysplasia compared to forceps biopsies alone with patients with GERD. And biomarkers have been identified that may predict the increased risk of progression to more advanced dysplasia or adenocarcinoma. And this most promising among these are the immunohistochemical markers staining for expression of P53. And AI-driven pathology system called Tissue Cipher. It is a process that utilizes the fluorescence imaging platform with the standard forceps biopsies, which predicts the progression of high-grade dysplasia or esophageal adenocarcinoma within 5 years of testing. The prognosis of Barrett's esophagus largely depends on the degree of dysplasia present at the time of diagnosis and the effectiveness of surveillance and treatment strategies. And early detection and regular surveillance along with timely endoscopic or surgical intervention can improve the prognosis by preventing the progression to esophageal adenocarcinoma. Due to significant impact on management, if Barrett's esophagus is associated with dysplasia, the ACG, that is American College of Gastroenterology, emphasizes the importance of confirming any dysplasia diagnosis with a second expert opinion with extensive experience in Barrett esophagus related neoplasias. And the surveillance protocol differs for the level of dysplasia. In no dysplasia condition, an endoscopy is recommended for every 5 years if Barrett mucosa is less than 3 centimeter long, and if the segment is at least 3 centimeter long, it is recommended like every 3 years. In indefinite dysplasia, in endoscopy should be repeated in 6 months, and patients on proton pump inhibitor therapy. And patient if the repeat endoscopy is unchanged, then the endoscopy should be repeated annually. And if there is progression to like low grade dysplasia, the low grade dysplasia management is followed. So and for low grade and high grade dysplasias, endoscopic eradication therapy is performed. Like after that, in low grade dysplasia endoscopy, in low-grade dysplasia, endoscopy should be repeated every 6 months until there is 2 consecutive evidence of non-dysplastic Barrett's. Coming to the endoscopic eradication therapies, it is used to treat like low-grade dysplasias, high-grade dysplasias, and early-stage adenocarcinomas. These therapeutic techniques include radio frequency ablations. This is application of radio frequency ablation to the Barrett mucosa using devices that ablate are like in 90 degrees, 180 degrees, and 360 degrees of the affected area at a time. And the complications of radio frequency ablation include chest pain up to like 2 weeks, and less common but serious complications include aspiration, bleeding, and surface laceration, deep perforation, and strictures. And next is cryotherapy. This can be performed using either liquid oxygen and cryospray or cryotherapy and applied through an inflated balloon that compresses the Barrett segment. And hybrid organ plasma coagulation, this technique can be used for small islands of intestinal metaplasia. Next is endoscopic mucosal resection. It is preferred for smaller and most superficial lesions, and EMR involves the injection of saline or other solutions such as glycerol and hyaluronic acid into the submucosal plane to raise the mucosal lesion, and it is then sucked into a cap fitted on the tip of endoscope and looped by a snare wire and cut by the electrocautery. The limitation of this method is the size of cap, so it generally recommended for the smaller lesions. And for larger lesions, if resected by EMR, like endoscopic mucosal resection, a piecemeal resection is required. So therefore, endoscopic submucosal dissection is done. In this procedure, it involves the first marking the margins of the lesion and then submucosal injection and cutting the mucosal edges along the line of marking and then submucosal dissection of the tumor from its bed. Next, endoscopic surveillance must be continued after complete eradication of intestinal metaplasia. And biopsies should be taken of any visible lesions randomly from the cardia and the distal two segment of esophagus, where recurrences are most likely to occur. The recommended intervals are as follows. In low-grade dysplasia, repeat endoscopy 1 year after the complete eradication of intestinal metaplasia, and then 2 years later. And after that, if there is no recurrence, then endoscopy should be repeated every 3 to 5 years. In high grade dysplasia, like repeat endoscopy at 3, 6, and 12 months is done following complete eradication of intestinal metaplasia. And if there is no recurrence at that point, then endoscopy should be performed annually. It is finished.
Okay.
Yes.
So, any questions or doubts regarding Barrett's esophagus? So, Nikita, when do you recommend esophagectomy in Barrett's, in patients who have Barrett's?
Sir, if it uh, in case of high grade dysplasia, sir,
High grade dysplasia with
more than like involving complete circumference and
risk factors, significant risk factors. Such patients and persistent dysplasia, patients who are and then obviously there is the conversion to malignancy is there, so that is another thing you have to be worried about. So high
yes,
grade
sir.
dysplasia, there is a tendency to 20 to 30% every year, malignant transformation. So these you have to be very careful, because the moment there is malignant transformation, the prognosis becomes very bad, because lymph node involvement, not only in the peri the cilia group and the this one group and diaphragmatic, they can also, in 20 to 30% of them, we can have cervical mediastinal lymph nodes also, because esophagus has this high degree of lymphatic plexus, and the anastomosis is so good that the even tumors of the lower esophagus will spread to mid and upper esophageal lymph node groups. So that is why any suggestion of persistent high grade dysplasia or moderate dysplasia turning to high-grade dysplasia with risk factors like smoking, alcohol, family history of esophageal cancers, and those patients who are not very prompt with their follow-up treatment. Such patients you have to offer this one esophagectomy, or some you have to at least initially you have to consider doing argon plasma or this one radio frequency ablation. In addition, you will have to offer them Nissen or 2-pay fundoplication to prevent acid reflux.
Yes, sir.
Any questions or clarifications? Final comments. Who will do that today? Karthik?
Sir, he did very well, sir. Almost everything was covered in this topics regarding the GERD and Barrett's.
Okay. Niranjan, final comments from you? Niranjan there?
Sir, well presented, sir.
Okay, good.
I think he has covered most of it.
Yeah. Sanya, final comments?
Same, sir. He has covered everything in very detail, both the topics.
So I think I keep stressing, I think Sir Niranjan, Lakshman sir, myself, the important thing is he is not reading from the slides. So it's important, he is well prepared, and I think he covered the topic well, and he was actually explaining the slides rather than reading from the slides, which is good habit, and he was fluent. So all in all, well done, Likith. Okay, I think if there are no further questions, we'll close the class. Thank you. Good night.
Thank you, sir.
Thank you.